Good morning, everyone, and welcome. Dr. Blank is going to be doing his talk on diabetes on Capitol Hill, and he received his Bachelor of Science with honors from University of Michigan, Ann Arbor, and he received his Doctor of Medicine from Finch University of Health Sciences, the Chicago Medical School. Dr. Blank completed his internship and residency in internal medicine at Wayne State University, where he also served as chief medical resident. He completed his fellowship in metabolism, endocrinology, and diabetes at the University of Michigan in Ann Arbor. Dr. Blank is dual certified in endocrinology, diabetes, and metabolism, and also in internal medicine after earning his board certification from the American Board of Internal Medicine. He has a practice interest in helping patients with type 1 and type 2 diabetes, along with other endocrine disease. He has a further interest in political aspects of medical policy and participated in visitations with members of Congress. Dr. Blank?
Thanks. We're going to get started. Appreciate it. I have a lot to say, and it's going to seem like a whirlwind, so hopefully I don't go too quickly. I'm going to start my timer. I'll just be cognizant of the time. If you have any questions, maybe we'll save them for the end. So I'm going to try to identify who's in government today. I think that's really important. I'm going to review the current congressional actions that are related to type 1 diabetes. And as you can see on the list, there's about 6 or 7 of them that I think are really important. 2 of them are not law. I wanted to tell you how they happen, though. And obviously, I can't cover every aspect of legislation. It happens on a continuing basis. I updated slides as of yesterday based on things that had happened in the last month or so. I have no conflicts of interest. Although I do want to tell you that I do advocate on behalf of patients, not for JDRF, but for ACE, which is the American Association of Clinical Endocrinologists. So JDRF does have an advocacy arm. It involves several bullet points. One is the Special Diabetes Program. JDRF also advocates for access to type 1 diabetes therapies and technologies. You may be aware not everybody with type 1 diabetes is a child, of course. And over time, patients with type 1 diabetes are covered by Medicare. And so the government has allowed that Medicare cover continuous glucose monitors. There are certain criteria for continuous glucose monitoring coverage under Medicare. And actually, we had been advocating for Congress to allow it, and suddenly out of the blue, CMS, which is the organization that runs Medicare, says, we're going to cover CGMS, and they basically cover 2 systems. One is the Libre system, and the other is the Dexcom system, Dexcom G5, not G6 yet. In order to qualify, you have to check your sugars 4 times a day and document that you're doing that. You need to be on multi-dose injections or pump therapy, and you need to demonstrate that you're using the information from your CGMS to actually take care of yourself. I mean, what's the point of having a tool if you're not using it? JDRF also supports low and predictable out-of-pocket costs. As someone who has accessed healthcare myself, I can guarantee there's nothing predictable about it, and I think that's a terrible thing. We want to reduce barriers of care, and JDRF advocates to eliminate exclusions for pre-existing conditions. This is huge. Pre-existing conditions means when you have a disease before you get a policy, they won't cover that policy. So if you go to the JDRF website, you can go down and look under the Get Involved tab, which is right in the middle, and you can drop down and have lots of options to take a look at. But the one right here that says Advocacy, you can click on that, and then you can see what the current initiatives are. So this is specifically directly from the JDRF website. That's our Capitol building. It was just renovated. Actually, it's beautiful. And if you haven't had a chance to go to D.C., I highly recommend taking in tours of Capitol and other highlights. So the federal government is made up of 3 branches, of course. Everyone learns that in grade school. We have President Trump, who's a Republican. We have 9 Supreme Court justices. There's there are more conservative justices than liberal justices. And we have Congress. Congress is supposed to have 535 members. There are actually some vacancies right now because of sudden resignations for one reason or another. Plus, in the Senate side, John McCain is very ill, as you're aware, so he's actually probably not going back to Washington, although he is definitely using his bully pulpit to express his feelings, as has happened in the last week if you've been paying attention for the, I think it's the CIA head. So anyway, there are 435 members. There are 238 Republicans, 193 Democrats, although there are 2 vacancies on the Democrat side and 4 vacancies on the Republican side. There are 16 human medical professionals. So these are medical professionals that take care of people. There's actually a very large number of veterinarians in Congress as well, so they probably won't apply to our conversation today. The Senate has 100 members, plus the Vice President breaks the tie, so there are really 101 votes in the Senate, and 51 Republicans, 47 Democrats, and 2 independents who actually vote with the Democrats. There are 3 physicians, and of course more than 80% of the Senate are men. And if you're paying attention to comments from Congresspeople like Nancy Pelosi, she announced that she's going to run for the Speaker of the House when the Democrats take over the House after the midterms. And of course, that's her prediction of what's going to happen. And she says, because there need to be some women at the table. One important piece of information, I think the most important thing, well, actually the 2 important take-home points today, besides contacting your own congressperson, is that Congress doesn't want single disease legislation. They don't want bills just about type 1 diabetes, or bills just about ALS, or bills just about, breast cancer. They want multi-disease legislation. So these are bills that will help a lot of people. There is a caucus called the Congressional Diabetes Caucus. There's actually a House side and a Senate side. And you can, and when I say you, I mean all of you and me. I cannot find the most updated information on who's actually signed up to be in the caucus. I have data as of 2017, but there's no active website that shows the current members of the diabetes caucuses. So these are legislators who believe in a common shared goal. And the goal is to educate members of Congress and their staff about diabetes and support legislation that will improve diabetes research, education, and treatment. So as of May 11, 2018, that was yesterday, 6 members who were in the caucus happen to be the 6 members who resigned from the House. So funny enough, everybody who was on the caucus, or actually no one who wasn't on the caucus resigned. I don't think being on the caucus makes you resignable, though. I think it's just a coincidence. So the Diabetes Caucus lost 4 Republicans and 2 Democrats who have resigned since the 115th Congress started this last year. And it is one of the largest caucuses in Congress. The Senate side has 35 members, 20 Democrats and independents, and 15 Republicans. You'll notice this is a bipartisan issue. And it's actually chaired by 2 women, one a Republican and one a Democrat. Diabetes is not a political issue in terms of parties. It is not partisan. Senator Stabenow from Michigan is on the caucus. However, her seat is up this year. Senator Peters is not from Michigan. And as I said before, the House has 168 members, but out of that 168, 6 have resigned. And again, that's bipartisanship. You've got a Democrat from Colorado, Congresswoman DeGette, and a Republican, I think he's a physician actually, Reed from New York. So the Michigan House members of the Diabetes Caucus, so these are the members from the state of Michigan who have signed up. They include 6 members. Mr. Conyers was a member, but he is now a former member because he's no longer in Congress. But I think the most important thing about this is who's not a member. And these are the people that you need to contact, and you say, why aren't you a member of Congress? I mean, a member of the caucus. I think that's very disappointing. And so if you go back, you have those that are, and mine is, but one of our senators is not. And I've included all the Michigan people because I know some people are here from Michigan, from all over the state, and I wanted you to see that. I also included Ohio because I think we have some Northern Ohio people here. Ohio has done a really nice job. Almost every member of the Ohio delegation is on the Senate or the House Diabetes Caucus. Only 3 people are not. And actually, I've updated my slides because the last time I gave this talk, 3 were not and now are, although 1 has resigned. and that's the one that's, I put a line through. Tiberi has resigned from the House completely, has left Congress. So Ohio's done a real nice job. So what can you do? You contact these people. You say, you know what, I vote for you, you work for me, and I want you on the caucus. That's what you have to do. So I did that. And so yesterday, I noticed Gary Peters still hadn't signed up, so I went to his website, and under here is the contact information. Every congressperson from the Senate and the House has a website, and every person has a contact information box. You click on it, you fill in your biographical information, because they really only want to hear from people who live in their district. Although I contact people whose patients live in their, my patients live in someone else's district. I contact them as well. And I wrote to Mr. Peters yesterday, and I said, I want you to join the more than 200 members of the House and 35 members of the Senate, including your own colleagues, as members of the Diabetes Caucus. If they're on the caucus, they're going to think diabetes. And so that's what you need to do. So people ask me in feedback from this talk in the past, how do you contact the people? That's how you do it. You go to their website, you can Google them, and then you click here, and then you find the contact. And it's really easy to contact. They will get back to you eventually. There's actually an option to say, I want him to get back to me, or I don't even care. Okay? So again, the Capitol in the evening. All right, so I'm going to talk about some specific bills that have, this one has become a law. So a bill is a proposal, a law is the law. I was involved in this. This is the National Clinical Care Commission Act of 2017. I put diabetes in parentheses because it used to be the National Diabetes Clinical Care Commission Act, but I told you before they don't like single disease legislation. So we took the word diabetes out, and we added a couple things to make it not just diabetes but metabolic disease, and it became a law. It creates a public-private commission to improve coordination of the 35 agencies that deal with diabetes. It's chaired by this is the proposal, chaired by a clinical endocrinologist, and we want to streamline what the government does related to diabetes. It is not specifically type 1 diabetes. I just want to emphasize that point. To evaluate and expand education and awareness activities provided to healthcare professionals. And basically, it's a 3-year program. It's supposed to be revenue neutral, although nothing in Washington is actually revenue neutral. But they came out in the last couple of weeks with the actual budget, and it's going to cost about $200,000 to staff it, and several $100,000 to actually coordinate meetings. That's actually a drop in the bucket. Of course, we got like $1 trillion budget, and we're talking about several $100,000. It's a lot to me and you, but it's nothing to Washington. So it's basically a commission to, let's say, organize D.C. around diabetes. It includes complex autoimmune or metabolic diseases, diabetes, or the complications. So we're talking about a lot. And it's endorsed by 40 organizations, including JDRF, and you'll see down at the bottom a lot of abbreviations. Some are medical, like the Endocrine Society, the American Diabetes Association, and some are not, like the YMCA. Alrighty. So I went to Washington. I'm here with Congressman Kildee, who represents the Flint area. He's actually a very strong supporter of type 1 diabetes and diabetes in general. There's 2 other physicians there, Dr. Gosain, who used to be the head of endocrinology at Michigan State, and Dr. Grunberger, who's actually speaking, I think, at this moment. So we went and we met with Mr. Kildee. Funny enough, I was supposed to go again in March, and it was the late spring storm in D.C. I don't know if you remember. There was a storm. I checked my flights. I checked my flights at the garage. I checked my flights on the shuttle, get into the airport, and by the time I got into the airport, it had been canceled. 2 flights all day were canceled. Of course, mine was one of the 2. So I missed out on the trip this year. So the Commission Act, let me give you a status update. In the 114th Congress, that was the Congress that ended in January of 17, or actually in December of 16, they got past the House, but it died in the lame duck session in the Senate. This was after the general election. So then it was reintroduced, and it was acted on very quickly, and it made it through Congress between January 9th, 2017 and November 2nd when President Trump signed it into law. So it's kind of cool to have a bill you're working on actually get signed by someone, by the president, in this day and age, because so many bills die. As you know, there's so much, there's a lot of bipartisanship that bills can't get signed. The fact that this got signed shows you how important this issue is and that it is a bipartisan issue. So the administration actually has to run this now, and they're working on seating the commission, coming up with the people who are going to be part of the commission. So the commission has members from all of these D.C. agencies, the Medicare agency, the CDC, the VA, the NIH, so lots of agencies, the 35 agencies that I told you, so members from those agencies, plus 12 members of the public. So if you want to be on the commission, you can write a letter to the Secretary of Health and Human Services, say, put me on the commission. Anybody can do it. It doesn't have to be a medical professional, and the commission is going to exist for 3 years, as I said before. So I'm just going to give you an update. As of a month ago, the administration drafted a letter, and they said it's going to be, the program's going to be run through the Office of the Assistant Secretary of Health, which is in the Office of the Disease Prevention and Promotion of Agency of D.C. They need to have a plan within 3 months of their first meeting, so they're actually getting nominations. And I know 2 people who are running for a seat on this commission, and they're going to have 2 to 4 meetings per year, and it's open to the public, unless they need to have a closed-door session. I can't understand why they would. They're not discussing personnel. They're not discussing confidential issues. So you can go to D.C. and you can see how this commission's working, or it's supposed to be streamed online as well. So pretty cool, if you ask me. I'm going to shift now to the Special Diabetes Program. This is the Advocacy Cornerstone. So that was the Commission Act. I gave you the update. It's pretty, very gratifying to be part of this. I was getting emails that Congress, that the Senate did this and the House did this. Now they're conferring, and then they signed it, and they passed it, and then it was going to the president, and they didn't know when they were going to sign it. And then I got an email saying, unexpectedly, he signed it, and it was just done. So pretty neat. So the advocacy cornerstone of the JDRF is the Special Diabetes Program. The goal is to advance type 1 diabetes research at National Institutes of Health. It does include prevention therapies for American Indians and Native Alaskans. Those communities have a huge burden of type 2 diabetes. So SDP includes type 1 diabetes research and prevention of type 2 diabetes. One of the programs is looking at beta cell replacement and type 1 diabetes outcomes. So the sub-programs within the SDP are the artificial pancreas, which is a huge buzzword nowadays, glucose control, diabetes, kidney disease, researching diabetes-related eye disease. We know that diabetes is the leading cause of blindness in the United States. Environmental triggers of diabetes and immune therapies for diabetes. So this is what they want to do with the SDP money. So the Special Diabetes Program receives huge bipartisan support. However, it expired in September of 2017, and it was attached to bills that did not pass. And it got reattached to bills that did not pass. And so it actually died. So the SDP died. However, it was revived as part of the general budget bill on February 9th. And the budget bill itself was passed overwhelmingly. You've got to have a budget in order to make the government run, and as you know, there were several shutdowns, and so that's what happens when there's no money. The SDP again expires in September 30th, 2019, so they're going to be going through this fight again in a year and a half. That's how things work. It included $150 million per year for type 1 diabetes research. There's been $2.5 billion attributed to SDP since 1998. So what I suggest doing is contacting your representatives and thank them for voting for this. I suggest doing that even if they didn't, because that makes them feel bad if they didn't support it, and that's my thinking. I mean, there's nothing like making someone feel guilty for something they didn't do by saying, thanks for doing it, right? So I'm going to talk briefly, I already alluded to this, the continuous glucose monitoring. I don't know if anybody is wearing a CGM. I'm guessing a good proportion of the room is right now. And so this has been an amazing tool to diabetes care. So finally the government said, hey, you know what, it's a great tool, let's approve it. They've only approved it for 2 systems so far. That's the Dexcom system and the Libre system. The Libre system, as you know, is basically a wearable monitor. Dexcom is a wearable monitor with alarms. So there are some differences in the technology. It's not approved for use with the Medtronic 670 pump as of right now. So I don't know if that's going to happen. I'm guessing Medtronic has, hotlines to Washington to try to get this approved. I'm suggesting they don't go through Mr. Trump's lawyer because that seems to be not a good thing right now. So, as I said before, if you want a CGM and you're a Medicare patient, and this is not applicable to children under federal programs, it is not applicable to private insurance because the private insurers have their own rules, you need to check your sugars 4 times a day. You have to log it. Okay, I want my patients to write down their sugars because, first of all, people who write down their sugars have better control, in my opinion. And second of all, I want you to have that durable proof in case the insurer comes at you. This is true for commercials as well. I want you to say, you know what, here are my numbers. I showed you I'm using the test strips. You need to continue to give them to me. So anyway, so you need to prove that you're using that information to better your diabetes, and you can't just be on basal. Well, of course, with type 1 diabetes, you're not just on basal. You need to be using multi-dose injection or the continuous pumps. So as I said before, we have Dexcom G5 is approved. The G6 has not yet been approved, although I spoke to a Dexcom representative yesterday evening because I wanted to ask her if it was approved or not, and she said not yet, but they think late this year they're hoping to have some more information. And the Libre is the other new system. Now, Medicare loves the Libre apparently because it's cheaper than actually having a meter with test strips. So you may see them moving towards that direction as well. I have a feeling we're not going to be doing finger sticks for much longer, which is a blessing to everyone's hands. Whoops. So again, thank your congressperson for supporting the bills that were going to approve the CGMS. They never got that far because Medicare stepped in and said, we're going to do this anyway. But thank your congresspeople. Again, guilt them into thinking, oh my God, I wasn't one of those people that actually supported it. Why didn't I do that? That's such a boneheaded thing to do. So anyway, also, I just want you to know that the Diabetes Caucus is where this got started. Okay, so the Reed and DeGette, Reed from New York, DeGette from Colorado, these are the ones that got this whole movement started. Okay, so interestingly enough, Mike Bishop, I don't know if anybody lives in his district, he's out in Oakland County. He's actually not running for office again. He said it's because his wife wants him at home. Mike Bishop wrote a letter on April 11th. I got a copy of the letter to the head of CMS that said, we want our patients, our constituents, to be able to use their cell phone for CGMS. And you may be looking at me like, blank, what are you talking about? I use my cell phone for CGMS. If you are a Medicare patient, this is a really important piece of information, and you're using your continuous monitor, your Dexcom, and you are using your cell phone, they will take it away from you. And Dexcom knows you're using your cell phone because they have access to that information. So don't use your cell phone if you're using your Dexcom and the government's paying for it. They prohibit you from doing that. That's ridiculous. Well, part of the thinking is they can't control the cell phones. They don't want to be held liability for a cell phone error. The cell phones haven't been tested. Only the Dexcom itself has been tested, and that's why they're saying it. But we all know that people are electronic nowadays. We're all like bots of our phone systems. And so that's really a stupid thing. All you need to do is sign, I understand my phone may break, it's not the government's fault, and we can live with it. But so Mike Bishop wrote a letter, 34 people signed it to say, you know what, we need to get this going. Actually, a huge bill in Congress was passed looking at telehealth and telemedicine. This fits in really nicely with that idea. So he wrote that letter. If you live in his district, thank him. Okay? I really want you to do that. Thank him for supporting it. He's going to be in Congress for another 6.5 months. So thank him for doing it. 21st Century Cures Act, this is another bill. It was supported by JDRF. It's not diabetes specific. It wants to make patient input a greater factor in the FDA's regulatory decisions, basically streamlining how the FDA works in chronic disease. It was supported, actually was sponsored by Mr. Upton, who's a congressman from West Michigan. It overwhelmingly passed. I mean, you don't see anything in Congress that passes like that. I mean, that's an unbelievable margin. And it was a $6.3 billion bill. Of course, type 1 diabetes falls under that purview. The Americans with Disabilities Act, I want to touch on that. Obviously, that's a 28-year-old bill that became law. It prohibits discrimination against qualified individuals with disabilities. So if someone's qualified to do a job, if someone's qualified to have access to a program, you can't discriminate based on a pre-existing condition. A disability is anything that impairs or provides impairment. And it provides protections for students with disabilities and also parents of children with diabetes. The key is it will not provide protections for children who go to private school at school, because private schools don't get federal funds. And so if you are a student and you go to a private school that does not get federal funds, you have no protections at the school. Now, if the school receives any federal funds, you do have protections. That would apply to universities. It would apply to public schools. The federal cost of insulin, or federal action on the cost of insulin, as you know, the price per unit of insulin is going up, which seems counterintuitive. Our TVs are getting less expensive. Cell phones get less expensive. Any technology gets less expensive as it's used, except for insulin. Doesn't make sense. And so you look at this graph here. I mean, this graph is shocking. So this is the price of insulin has gone up, and the graph starts in 96 and it goes to 2016. So this is 20 years. I mean, we've gone from the unit price well under $100 to $250. So what's happening about that? So there's a lot of smoke. There's no fire yet. We need to get the drug makers in front of Congress. We need to embarrass them, shame them. You need to call your congresspeople and say, why is this? This is counterintuitive. It's a money grab. And that's what you need to do. So not much has happened. A new letter just came out again by the Diabetes Caucus about this issue. But several people have been vocal. Mr. Sanders has been vocal. Mr. Cummings has been vocal. The leaders of the Diabetes Caucus have been vocal. But again, go to the website, call the number, be a pest, okay? Be a needle in their side every day. This is a bill that died because it got swallowed up by the budget bill, and it was actually passed as an amendment to the budget this year. So the Protecting Access to Diabetes Supply Act of 2017 is very interesting. So basically, if I'm a supply company and I want to sell to Medicare beneficiaries my diabetes supplies, I give a bid, and Medicare decides if they're going to accept it or not. And as part of that bid, I'm going to say, these are the supplies I'm going to give and have my patients have access to. This bill enforces that bid and says, well, you said you were going to give meter and test strip from company A, but now you're giving it from company B, you can't do that. So that actually makes it illegal to do that. It makes it illegal for suppliers to incentivize you to switch because it's cheaper for them. So if you are using a supplier and you're a Medicare patient, this is Medicare, okay? Of course, the government has no influence over suppliers when they're dealing with private insurances. And you're switched, and they didn't ask you, you say that's illegal. Okay, you call the supplier. You can call, I don't care who you call, you can call the government. That's not legal according to this law. Now, I don't know how the administration is actually going to enforce the law. Obviously, the laws have to be enforced. But they can't make you switch, or they can't influence or incentivize you to switch. And they also supposedly, I'll faint when I see this actually go into effect. they can't make you change the meter that you're already using. So let's say at 64 years old, you're using a meter, which I'm not going to be commercial, but let's say it's a specific meter from a well-recognized company, not a piece of junk, okay? The term I use in my office are pieces of junk or pieces of garbage. But, and you switch into Medicare, they can't make you switch. So I think that's a really important piece of legislation. I've yet to see this actually benefit my patients. I'm hopeful. It just became law when they signed the budget. So let's see what happens. But this did become law. And it became law not as its own bill, but as part of the budget bill. So I'm going to give you, so those are the most important pieces of current legislation or recent legislation. I'm going to talk now about legislation that we live under and what the Republicans wanted to change, okay? So this is the last half of my conversation, and then we'll have some time for questions. I'm going to hopefully go through this pretty quickly. Am I going too quickly for anybody? No? Actually, any questions so far? Yeah, you got a question. Question was, how does the Libre system work? So basically, it's a sensor and then a meter that you wave over the sensor and you can see your sugars. It doesn't have alarms, for instance, and that is available now. So, yep, 2 questions. Gentleman first.
Yeah, you mentioned and showed the graph on the cost of insulin. Is there a reason that they haven't passed a law where insulin should be given like they give out methadone?
I'm sorry, can you repeat the question?
Why is it that the insulin cost is so high where a dope addict can get methadone at no cost at my taxpayer dollar, but I can't get my daughter's insulin like they get that drug?
I have no idea. It's a great question. You know, I'm guessing it has to do with the cost to the public of not giving methadone is more money than the cost to the public of giving methadone. But there's a lot of illogical policy.
Hi, my name is Mark. My daughter is on a CGM. It is the Dexcom G5 system. And she's on Children's Special Healthcare Services, which I understand uses the Medicaid system as far as billing. You mentioned a couple times in the slides that this was approved for Medicare through a decision by the U.S. Centers for Medicare and Medicaid Services.
Yep, doesn't apply to children.
If it's approved by this same center, why is it not having so much trouble?
I actually don't know the answer. I think it's because children's authorization is under something called CHIP. So it's actually a different program. CHIP was actually on the chopping block too. You may be aware a lot of states started sending out letters to their patients who are under CHIP, which is the Children's Health Insurance Program, saying that we're running out of money, sorry. Michigan did not send out letters because Michigan had planned for Congress to not reauthorize it and had actually been budgeting for it ahead of time. So that's one thing that the Michigan government did well, I think, ahead of time. So it doesn't apply. And so I think that's a huge problem. And call your congressman and say, you know what, CGM is incredibly important. Be a parent of a child, and you're checking sugars all the time. I mean, how many parents are in here don't sleep at night because they're worried about their children? Everyone, right? Right. I mean, I work at the diabetes camp, and we have staff devoted to staying awake to monitor children. And in the diabetes camp, by the way, this is a promo for the camp, is great because it gives parents a week off from actually, you know, it's like the 1 week a year you get some sleep, right? Although, if you're like me, you're probably still worried about your children. So there's no logic. There's no logic. Call people. Be a thorn in the side. That's the only way that something gets done.
Do you have any idea how many representatives or senators have diabetes, or any of them that have families of diabetes?
Well, I mean, if they're American, and they are, I mean, a lot of people have diabetes. There's probably not a lot of type 1 diabetes. And the proportion of, and Congress people have the worst eating habits of anybody. I mean, I don't know if you've ever, I mean, I'm guessing it's a lot. I don't know. So, all right, I'm gonna move on, actually. I'll take questions at the end, and I'm happy to stand over here and take questions. So we'll talk about the Patient Protection Affordable Care Act. It's Obamacare. Became law in 2010. There are actually only 2 goals of Obamacare. One is to allow citizens to be more job mobile, What do I mean by that? If you have a job and you like your insurance, you're afraid to change jobs because your insurance will change. And the second is to increase the quality of life for many and reduce the most common cause of bankruptcy in the United States. These are actually two stated goals of Obamacare. That's it. So it became law in 2010. It survived a court challenge in 2012 relating to the individual mandate. The aim is to increase insurance coverage, and that includes increasing Medicaid access. Michigan is an expansion state, and so actually they're trying to restrict that now by putting in work rules. This is all in the news in the last week or two. I'm talking about federal level, so that's why I'm not addressing the Michigan issue. But there's going to be some new work requirements that are going in that are actually going to be challenged because they are against, I'm blanking on the bill that requires equal protection under the law, regardless of race, gender, economics, that kind of thing. Provides state-based marketplaces where individuals can purchase insurance, and the federal government provides subsidy for those living under 400% of the poverty level, which is $98,400 for a family of 4. The law says in order to be a health insurance plan, you have to have certain requirements. One is a community rating. Basically, that means you can't be judged based on your pre-existing conditions. You can't charge certain people more than others. It bans dropping members who become ill. It bans price discrimination on pre-existing conditions. Children and dependents can stay on the plan until they're 26 years old. This is probably, bar none, the most popular aspect of Obamacare. This would probably survive as a law by itself. And it bans lifetime or annual caps on coverage. So the Affordable Care Act has essential health benefits. I'm not going to list every one, but they basically provide for preventative care, maternal care, mental health care, pediatric services, birth control. This is actually one of the controversial issues. There was a Supreme Court case brought by the Hobby Lobby company because they didn't want to provide birth control to its employees. It actually eliminates Medicare Part D. Medicare Part D is the drug portion of the Medicare. Right now, if you have Medicare, you get coverage up to $2,850, and then you don't get any coverage until almost $5,000. So you have to cover $2,200 on your own, and that gets very expensive. So you can go from insulin being covered to not covered at all, and you have to shell out, $2,000. And so people can't do that. It eliminates Medicare Part D by 2020 and replaces it with a 25% copay on medications. And the estimate is a $5,000 annual savings. So who does this affect? This affects, obviously, people who are 65 and older and people on disability. So those are the patients who are using hypertension medicines, cholesterol medicines, diabetes medicines. So the complaints of the Affordable Care Act. So it provides, the one complaint is that there's lack of access. You can have insurance, but your doctor doesn't take that insurance. Okay? That's a huge complaint. There are a lot of plans that doctors don't take because they're difficult to deal with, or they don't provide reimbursement, or you never see any reimbursement. And so doctors are not taking those plans, and so you have basically catastrophic care where a hospital will take it, but a physician won't. And we don't want patients in the hospitals. We want them in the office because the hospital is the last place that I want my patient. The marketplace insurance programs are disappearing. Insurance companies are not finding profit, so they're withdrawing. So the big news was that one of the East Coast Blue Crosses said, we're going to have to leave the marketplace because we're getting huge deficits from the marketplace. Another complaint is that it costs $1 trillion over 10 years. However, that $1 trillion cost may save $100 billion in deficit savings, so that's 10%. So you got to spend a lot of money to save money. So the Republicans, shortly after the inauguration, came up with the American Health Care Act, and this started with an executive order by Mr. Trump the minute he was president, or became president, but it failed to achieve enough votes in 2017. And then Mr. Ryan, who's the Speaker of the House, said, Obamacare will be the law. And he basically, it was a statement of resignation. We're going to be stuck with Obamacare. That's what he said. Now, interestingly enough, Mr. Ryan's leaving Congress himself. He's not running for re-election. So the CBO, the Congressional Budget Office, that's the organization that basically says how expensive a bill is going to be, said it's not a repeal of ACA, although they wanted to repeal and replace. It would increase the number of uninsured people by 24 million people. I think that was by 2024 or 2026. It would lower the deficit by $337 billion. So the Republicans' bill would actually cost less money, but 24 million people would lose insurance at the same time. It would decrease Medicaid expansion, eliminate the penalty for not having health insurance. Remember, we talked about the individual mandate. It would decrease financial assistance for the health marketplace, and it estimates that employer-sponsored plans would actually decrease by 2 million and 7 million over the next 8 years. So if you had an employer that gave you health insurance, there was a chance if you worked for one of those employers that eliminated, you'd be part of 7 million people who lost their insurance as well. So the effect of the American Health Care Act on Medicaid, it's important to note, this is a side comment, that diabetes represents a disproportionate percentage of Medicaid use. Why? Because diabetes is a very expensive disease. It causes people to lose value. I mean, their savings goes down. They can't afford health insurance, and so they need Medicaid. So the effect of this bill on Medicaid would cause a decline in funding of $840 billion over the next 10 years. Medicaid currently covers 70 million Americans. 25% of Michiganders are on Medicaid. And the CBO estimates a loss of 14 million people would lose their Medicaid. Medicaid covers 50% of childbirths, and 2/3 of nursing home health care coverage is provided by Medicaid. So we're talking a lot of people. So an interesting study, the number of Medicaid-enrolled patients with newly identified diabetes increased by 23%. So what that study basically shows is that in expansion states, people who got Medicaid were diagnosed at a higher rate of 23%, although those who were not in Medicaid expansion states, the increase in diabetes only went up by 0.4. So basically, Medicaid is a ticket to figuring out if you have diabetes or not. And the American Health Care Act was going to eliminate that, or reduce it greatly. I shouldn't say eliminate it. So basically, the House passed the bill. You'll see by a difference of 4 votes, including some Republicans who voted against the bill. This is a very bipartisan issue, by the way. It shifted powers to the states. It allowed employers to get out of Obamacare. It eliminated subsidies and replaced it with tax credits. Well, tax credit, the argument goes, only benefits people who pay taxes. And so many of the people who are in the marketplace weren't paying taxes. I'm getting a wave from the back, so I got to move along. We started late, so I'm going to go for a few more minutes, and you're more than welcome to leave if you want. There was also a penalty as part of this bill. If you didn't enroll during the enrollment period and you wanted to enroll late, they could actually charge you more money because the pre-existing waiver was kicked in. And it's called health status rating. They basically can charge you more for having certain diseases. So the concern for people who lived in opt-out state would be that they would have higher premiums for their health care. Interestingly enough, they did give a 62-day window, so if you lost coverage, you could get back in within 62 days and not pay more money. But a lot of people don't realize how fast 62 days goes, and it did not exclude coverage for people with pre-existing conditions. So they wanted to create a high-risk pool to cover that, so Mr. Upton said, well, let's give some more money to that, and that caught support. They basically threw another $8 billion to the $100 billion that was added in for the high-risk pools. There was another amendment by a gentleman from New Jersey that allowed communities to partially waive the community rating and allow states to set up their laws where they could charge more for older patients. So basically, they were adding amendments onto amendments. Basically would eliminate the individual mandate, so you didn't have to participate. The idea with Obamacare is we're going to make everyone participate because the healthy people are going to help support the people who have disease. And it modified tax credits, so it basically replaced the cost-sharing subsidies. So instead of getting money, you just won't pay as much in tax. Again, that affects lower-income people more than it affects higher-income people. So basically, the American Health Care Act said we were going to charge more for older people. we're going to charge more for sicker people, and guess what? The bill did not survive. So the essential health benefits of Obamacare all still applied. However, states may decide that they don't want to have that, so they were giving the power back to the states to decide if all of those benefits from Obamacare would exist or not. Preventive benefits, though, still were required. So the House passed the bill, the Senate said we want our own bill, and guess what? They couldn't agree with it. So the organizations who supported the American Health Care Act were primarily conservative. The organizations who opposed it were primarily medical, including AARP, but American Medical Association, the internist, the endocrinologist, JDRF, the American Diabetes Association. So a lot of people opposed the American Health Care Act. The JDRF said, this is terrible. And so it did not become law. The Senate bill was created by 13 men. No women were at the table. I think that's important to note. It allowed for age rating and higher charges for pre-existing conditions. Again, this did not pass. But what did become the law of the land after an executive order was that Trump said we're going to allow interstate insurance plans and extend the length of short-term plans. Short-term plans are plans that actually get around Obamacare. These are sort of like your COBRAs. These are your temporary insurance programs if you're between insurance plans, but they don't have the same protections. And Mr. Trump said, well, we can let these plans go on for a longer period of time. So patients were getting into these cheaper programs that don't have the same protections. And so Mr. Trump allowed for that. So that was signed into law as part of the Tax Cuts and Jobs Act. So this is the tax bill that everyone knows about. It became part of that law. It's interesting how Congress adds on things that are totally unrelated to tax and to budget bills, because those are the only bills that seem to get passed. And the CBO said that the repeal would save more than $300 billion, raise premiums by 10%, and lead to loss of insurance for 13 million people over 10 years. That does not include the people who are in the short-term programs that don't provide the same protections. So in February of this year, he extended the short-term health care coverage from 3 months to 12 months. The tax bill, as I said, eliminated the individual mandate. And enrollment in 2017 declined by about 5%, although enrollment was shorter and outreach funding was down 90%. So basically, the government gave 90% less money for outreach, and but only 5% fewer people enrolled in the marketplace. So at this point, I just want to remind you, call your legislators, promote your cause, whatever it is, support diabetes patients, and follow up with them frequently. I think that's the real message.